السلام عليكم. بسم الله الرحمن الرحيم. We are talking today about hybrid imaging in pediatric oncology, which is something interesting to know. So let's start about what is hybrid imaging. They mention the hybrid imaging is like something the benefit you can take from fusion of two modalities. Usually in these days we talk about PET CT, PET MRI. This start from long time ago, even between MRI and CT, between ultrasound MRI, between whatever two modalities, so you can get the benefit. Right now become like more and more advanced. Many tracers used in PET CT, PET MRI, SPECT CT as well. So that's the reason that's become now like more and more advanced. So this is what is called hybrid imaging, fusion between two modalities. So you can get the good benefit between both modalities, and you can have the much benefits to the patient. Okay, so let's see. This is the history, how it started, the hybrid imaging history. This slide from Dr. Ahmed Talat, rahimahullah. He was one of the amazing pioneers in our field, and he gave me this presentation, and I take it from him, rahimahullah. Okay, so this is the usual in the practice now. You can see that the most widely distributed is the PET CT. This actually is fusion between the CT images, low dose CT, or sometimes diagnostic CT, and the PET images, and finally you get the fusion between them. So this images give you data, and the CT give you data, and the fusion between both of them give you data. So this is the benefit. Right now, it's become more now distributed in many places, even in Egypt, many other countries. You can see that there is PET MRI. Also, the benefit that you get, the benefit of MRI, the benefit of PET images, and the fusion in between both. So this is the hybrid image. So what we can do in oncology, especially now we're talking about the pediatric oncology. This is the commonly used indication in pediatric oncology. Some of this indication are settled, like lymphoma, for example. They use PET CT, like, let's say, that is routine practice in these places. And some of them are still under research, some of them especially regarding the PET MRI issue. So why use the most widely distributed tracer you always hear about it is FDG. This is the most widely distributed and is linked usually with the PET CT. This is the most easy tracer, most commonly used, short half-life time, and this is the usually used tracer. Also, the diagnostic sensitivity and specificity in some cases reach 100%. So let's go to real practice cases, which I like more to show you. If you have some of these cases in the real practice, either come to you, for example, when you go for make a comparison, or you see like you go in one institute working with these images, how you can do. So actually there is many frequent scenarios. Either come to you to assess this patient who have a baseline assessment. He have already known that he's, for example, lymphoma or whatever, or he don't know and they want to make sure that this is, for example, lymphoma. This is what's called baseline. Or he take treatment for 1 cycle or 2 cycles of chemotherapy, and you want to see the response, which is called partial or complete response, depending in many factors. Let's see this example. This patient, as you can see, there is active hypermetabolic lymphadenopathy, which is going in the mediastinum. Everyone can see that this is mediastinal lymphadenopathy. And here you can see that there is activity in the fusion, in the bit, in the fusion images. This means that this patient have active, I think this was lymphoma, so this is active lymphomatous disease, supradiaphragmatic. And this is the beauty of bit, that in one single image you can see, for example, that there is no infradiaphragmatic, there is no spleen involvement, for example. Sometimes you have some pitfalls, for example, this. Anyone know what could be this in the hand? Let's have some active participation in chat. If you have anything, just mention in the chat so we can have real practice. So what do you think about this uptake in the hand, in the forearm? Do you know what it could be? Any suggestion? No. Brown fat usually in this side will show you brown fat. But what do you think about here? This is in the muscle. Do you agree that could be muscle activity? Soft tissue activity, muscle? So muscle activity. Agree. Why muscle activity in this patient? What he did before he started the study, the exam? You know, this is a FDG, like glucose metabolism. So if somebody did some muscular activity, yes, perfect. So you have to be careful about some pitfalls. Let's go on another pitfall. Someone just mentioned it, Dr. Assam, I think. So what do you think about this? Which one is lymph nodes? Which one is mix between lymph node and something else? What is called? You just mention it now. What is called now? This is called as brown fat. Yes, this is the brown fat. And usually, especially in the winter, who have brown fat, it make him warming. So if the patient came in the bit sees, like you want to do the bit, we usually advise him to rest and because you can see that this brown fat is working here, and there is like some confusion. Is it lymphadenopathy or it brown fat? But after they take like a late image, and yes, they agree that this is lymphadenopathy in this case. So let's go in another image. What this image? Bit. And what this image? Fusion. Fusion between MRI and bit. So this is bit MRI. In 15 years old girl is diagnosed as Ewing sarcoma. And you can see that there is high activity in the pelvic bone. I think everyone will agree that this is typical pattern of Ewing sarcoma. What is the beauty here? The beauty that you can, in one single image, not just to say that this is a primary, but you can say also that there is some secondaries. Take care, because this is one of the pitfalls that the patient, if you have heart activity, which is usual, and the brain activity, they are much consuming for the glucose. So usually you have this is the normal activity, okay? So if you see that there is multiple lung lesions, so this patient have pulmonary metastasis. Agree? You agree? Everyone agree? Yes. So this is the beauty of fusion hybrid imaging. So in one single image, you can have what is called one-stop shopping. Like you get everything what you need to know from one image. It's not very easy like this, but this is the benefit that you can get. Okay. So from your experience, you find like lesion active in the distal femur, what is your provisional diagnosis? It is, yes, the answer is here. So it is osteosarcoma. Yes, usually it is osteosarcoma. And it have some of this criteria, as we know, the aggressive lesion. You know, the aggressive lesion have wide zone of transition. You remember when we talk about this, this is what you have to mention for the viva. Yes. So wide zone of transition, and there is soft tissue component. And in that case, yes, I can come back. So this is the osteosarcoma case. If you remember how you can mention that this is aggressive lesion. So this is aggressive lesion, everyone agree. Again, you have some bit folds here. This is not metastasis. This is what is called, everyone now knows what's called this one? Called what? Brown fat, yes. Brown fat. And also can note something. If this metastasis or not, what do you think? This patient have in his colon, there is high activity, hypermetabolic activity here. What do you think? This patient have this is metastasis or not? Not metastasis. Sometimes the colon have high activity, yes. And there is some drugs. Someone know what the drug can have high metabolic activity in the colon. It can have the common bitfold. They like it in the exam to know about it. If you find high metabolic activity in the colon, I mean, I don't mean this case in general. If you find high metabolic activity in the colon, diffuse. What do you think? Metformin, diabetic patient, metformin, you know about this? Metformin, yes, metformin, okay? So sometimes you can have this, there is no metastasis in this case. This is the beauty if you want to know, if you go through these images, you have to know the pitfalls and how you can find what is lesion and what is not lesion. Let's see these images. So one of them is the baseline and one of them after treatment. So if you give 3 choices, this patient have partial response, complete response, or he is stationary. Which one you choose? After 2 cycles of, yes, complete response. So this is again one of the good things that you can see. You can note something here. If you go to the CT and you want to report CT alone, what you report? You report that is still there is partial, right? But in the bit, what do you think? There is a complete metabolic response. So you see how it will affect your management. And in this case, you see that if you go to report just the CT and you don't have the bit side, you will say that this patient still have some residual. But in the real, this patient have complete metabolic response, CMR. Okay? Complete CR. Let's go to this patient who have a known case of lymphoblastic B-cell lymphoma. And can see that he did in pediatric oncology, he did PET MRI. In PET MRI, you can see that there is some lesions, right? Some lesions. And you can also see some metabolic activity in the bones. So you see the primary and you see the activities in the bony lesions, vertebrae and appendicular, proximal appendicular. Yes, proximal appendicular lesions. After he takes the chemotherapy, what happened? Can see the difference? Yes, I can see. You will say in the MRI that there is still, if you just report the MRI, you will say that there is still some changes. And maybe if you did CT, you will say the same. But if you go to the bit, you will find that this patient have almost complete resolution. So this is the good thing. Some people can have partial response as well. Okay, so if this happen, then you will report it as partial response. So any other clinical scenario can happen? Yes, there is other clinical scenarios happen. For example, this patient who came after treatment by this active lesions. And you can see that this is metabolic activity coming with many sites, left supraclavian region and right paravertebral and suprarenal, right, of the site of the neuroblastoma, relapsing, this case of relapsing neuroblastoma, okay? So also just to mention or to know that we usually in neuroblastoma, we use most widely distributed MIBG. And in some types of resistance, we use of non-MIBG uptake, we use the FDJ, but there is other tracing, other new tracers, okay? For example, this patient, they use the MIBG and it was negative, okay? And they used the FDJ and it was positive. And there is another tracer that also used, and now they have some research about this F18 DOPA PET-CT. It have very nice outcomes regarding the diagnostic ability of this tracer. You can see that this case this tracer can detect many of those lesions in neuroblastoma, where especially the relapsing type, as you can see. Also something to mention, depend also sometimes in the type of the neuroblastoma. Is it well differentiated or non-differentiated? Depend which type it can take. For example, MIBG, which going more with the well differentiated, which type will take such tracer like FDG. And if there is any other application for same idea, yes. Let's go to see something about the neuroendocrinal tumors. This patient, if you go just to see the MRI images without bit, you see that there is lesion here and restricted in diffusion, ADC here. And this lesion, you will put like some differential diagnosis. But if you go and do this tracer, which is specific to detect the neuroendocrinal tumor, the most common neuroendocrinal tumor, the most well differentiated is, which one? Is carcinoid tumor, right? So this is carcinoid tumor which have high activity, okay? So what could be this tracer? What's the name of this tracer? It is something called gallium dotatate. Usually, we use this gallium dotatate for the well-differentiated tumor like carcinoid, and the FDG bit for something that doesn't take in the gallium dotatate. So it will be not well differentiated. Okay, so this is again the same idea. Okay, let's come back for some challenges while you read the PET-CT and PET-MRI. So when you go, for example, for this lesion, you find that in CT, almost you can detect barely that there is something here, maybe. But if you go to the PET, there is again something tricky, that there is activity within the heart, as we mentioned before, that there is normal physiological uptake, right? So what is going here? There is another lesion here. In such age, we can think about what is one of the, yes, rhabdomyosarcoma, which is the case here. So take care about that. We can detect through some lesion in the brain and some lesion in the heart, which is usually avid uptake in the FDG PET CT. Okay. Let's go another example, which is challenge when you find something in the CT and something again in the PET. There is uptake, but the uptake in the PET is not very high, and they think that it could be a mass lesion because the patient already have history of malignant peripheral nerve sheath tumor. When they take the biopsy from this lesion, it is show that it is just reactive hyperplasia. So this is one of the pitfalls, that it can give you a false positive, that not everything you will see, even in high in the PET CT, that you can say that is malignant 100%. It can be, again, something false positive. So you will know this by pathology. Another example, if you go to check for this lesion, which is avidly uptake in the PET, and in the MRI also, you can see that it look like not benign lesion, it look like suspicious lesion, right? And finally, when they take the biopsy from this lesion, show that is no, this is a necrotic lesion. It is not malignancy. There is no malignancy. It's just infective process. So again, it can be false negative even in the presence of primary. But common is common. You have to mention that still could be metastatic lesion. Now we know about this pitfall. It is called brown fat. We mentioned it many times. In the MRI, you detect something. It is not active in the PET, in the fusion image or PET. So is it still suspicious? Yes, still suspicious. Sometimes it doesn't show uptake. Some tumors, it cannot have some uptake in the PET, but still suspicious. And this is what happened with this patient. Did PET MRI, and they find this lesion proven to be, after that, in the follow-up, that it disappeared after treatment. This means that it was active lesion. So one of the good things that we usually use in the PET, especially for some lesions, we cannot take biopsy from every lesion. You cannot take a biopsy from every lesion. You have to follow up this lesion and see the pattern of behavior after treatment. Again, another lesion, and you follow up, and finally this patient have good therapy. Even in the MRI, still some changes, but it show good metabolic response. And this is the issue, how you can manage the way between morphology and metabolism. For example, here the morphology give you an MRI that the borderline is here, but the uptake and metabolism is here. So there is different, sometimes there is a different borders. For example, in this lesion, which is proven to be osteosarcoma in the left humerus. Some of the tumor we just mentioned that can be negative in PET, but still it is malignant. It is still as synovial sarcoma. Some types of mucinous tumors as well. So take care, not everything doesn't show uptake in the PET. You think that it is benign, and it is no. It can still. This is the beauty of hybrid imaging, that you have to take the benefit of all the modalities you have, not just single modality. And also, when you go through the reading, you have to combine the reading. You have to check the CT images, take the benefit, PET images, and finally the fusion. Even the fusion, you can take a benefit of this together. Sometimes it can have high uptake, But in the CT is usual something that we know already, like fibrous cortical defect, and can have high uptake, like fibrous dysplasia, fibrocortical defect. All this can have false uptake, false positive lesion for malignancy. So in that case, and also you have like sometimes the clinical scenario can face after follow-up that you want to see this is it recurrence of post-therapy changes. For example, in this case, patient who have Ewing sarcoma and there's high uptake in the initial, then you give a treatment, then still there is some uptake, and this proven to be post-therapeutic changes. Not everything after treatment can be like residual. It can be like this patient who have post-therapy changes. Some of the diseases now, like NF, adding the bit in this patient is very beneficial. You can see this patient, they did for him MRI, and you can see in MRI the benefit that you can detect easily the pattern, soft tissue lesions, plexiform neurofibromatosis, so you can know the pattern. So in this case, there is no avid uptake. There is some uptake along low-grade uptake along the lesions here, which is going with the context of this is a benign neurofibromatosis. Let's see another patient. This is plexiform neurofibroma, but you detect here uptake, which is avid, high uptake in case of neurofibromatosis. So usually this patient there is malignant transformation. And here the beauty that you can make the treatment or a surgical resection in just this, if you need, depend on the surgery decision, but I mean, you don't have to make major resection. You need to make the malignant transformation section, for example. And this is the beauty again of such addition. And in the brain, now there is some new tracers. They are very helpful. For example, this case, which in MRI, maybe there is vasogenic edema, you can detect. In the post-contrast, maybe you cannot detect any avid enhancement. And in this tracer, which is 11 C-methionine, methionine, this one you can see that there is high uptake, and post-treatment, this patient, you don't need to make major resection, you just need to make resection for the part which is avid in this case. Okay.
Doctor, I have a question. Dr. Mahmoud?
Okay, the question we can answer in the end. Just to finish and we go to the question. Okay, so this patient again, you get a good assessment that you can know that this case there is avid uptake here, and you did the resection, so you manage the surgery. You can make a good management through such case. And there is part you have to be also, this some challenges you have to know that there is a part in this images. When you make analysis, you will find that this called incidental lesions. And when you find incidental lesions, you have to be careful because it can make a distraction or deviation for your way of thinking, as we know. So here, for example, this patient have Ewing sarcoma, as you see, and you know this by CT and X-ray and so on. After you get the detection, you note something. You note that there is calcification in the CT while you scroll through the axial images. So what you'll do, we'll do ultrasound. Through the ultrasound, we find another incidental lesion, which this patient have. You have teratoma. So not everything you can see, it can be metastasis. No, it can be incidental finding. Sometimes you can face some thyroid nodules, renal cysts, bone island. Not everything you will see in the images, it can be just metastatic lesions. Even sometimes when you go to the CT alone, it is very subtle. Maybe here you can see that this patient have very subtle enhancement. Again, when you do a PET, again, there is no such uptake. MRI, this is the combination between CT and MRI. MRI, you can see that there is abnormal signal, which is clearly detectable here, right? So, but still, you don't have uptake in the PET. Is it? You can say that, no, there is no metastasis, there is no uptake. No, you have to be careful of this. So still, this is suspicious. Patient have history of HC. So we'll not neglect this. We'll not ignore that. That's what we'll do. We will do such assessment for this, and later it is known to be metastatic lesion. The addition of diffusion, if in such cases, is very beneficial. And there is also like whole body diffusion, or what is called DWEBS, or whole body diffusion, whatever you can call it, that it help you in patient assessment. It will help you, especially if you have it. For example, this is the FDG bit, and this is the MRI. So you can see that they are very similar in detection. This using the cellularity. So whatever here is more cellular and more have high cellularity, you see that this patient have high restriction in diffusion. And here detection of metabolism, whatever you see that have high uptake in FDG, which is the most widely tracer used. So you will find that this is high uptake. And there is some, again, pitfalls, but it is very useful tool you can use. This is just diffusion between T1 and the diffusion. You can see that there is some similar images, colorful images as well. So this, again, the bit CT, the fusion, and here you can see the fusion of the MRI. This picture I take from my colleague Ayman. So this was here real life cases, which he did. I did also some of them. So this, you can see that this case is very, very useful to use the diffusion as whole body or even as a single part. Can you see that even the hidden area beside the spleen, you can detect it in the MRI diffusion as well. Okay. So this some pitfalls there is present. Yes, some pitfalls also in the diffusion. You have to be careful that there is some benign pathology, there is some distortion, some artifact. You have to be careful and to know about this. I hope that you get a benefit from such lecture. How I can differentiate this question here, Dr. Maha, how I can differentiate between recurrence, residual post. This is a very difficult question because it depends in the scenario. Which scenario you have. For example, if we have a mass lesion and then this patient, for example, have good response, in the metabolic activity, but there is still some CT changes. So what they do usually, they follow up with this patient, and they consider it like complete metabolic response, but they don't let him to go. They usually follow up with him, and if there is any suspicious criteria, they usually take a biopsy. It depends on the clinical scenario and the entity who decide what is going on. But generally is not. It's a challenge. They have this challenge usually. Is it recurrence, residual, or post therapy? That's what I mentioned, that you have to combine all the patient data, the previous images, the current images, then you can get the final. So any other questions before we go to next? Session or next break? I think there is a break. Will be, or there's any other question? Okay, no.
Doctor, thanks for answering the question. But I have another one.
Yes.
Does the post-therapeutic changes make a metabolically active uptake in the PET-CT or MRI?
It can have some metabolic activity, but usually if it is post-therapy, it is low grade uptake. That's the issue, that they think usually that it is not, and also the comparison with the initial one. Is it like, for example, some tumor, they have low grade uptake by its nature. So you have to be careful, because some of this is still suspicious if it has just low grade. But for example, if there is lymphoma and it have very high metabolic activity, and right now after treatment you have very low grade activity, then in that case usually you consider it as this is both therapy changes, and you have to follow up. But it depends on the clinical scenario. Yes.
Okay, thanks, doctor.
Thank you. Okay, so we have about 5 minutes break before we shift to, I think I have to stop share my screen. Then we have the next session after 5 minutes, I think. Yes, after 5 minutes with Dr. Sarah Wahid Tantawi. She's our colleague, and she's a biology consultant with subspecialty in cardiac images. She is also have been certified with FRCR, and I think she has a very interesting lecture today. She would like to give to us about the basics of coronary CT. This is the cardiac. Cardiac right now is something they like in the exams, so be careful, because maybe you will face some of these cases in practice or even in the exam. I hope that you will enjoy it. So we'll take like 5 minutes break before Dr. Sarah will start. Dr. Sarah, are you here?
Yes, thank you so much.
Okay, thank you. Okay, so you have two options. If you like to start right now, or you stay 5 minutes, whatever you like.
It's okay. We can start on time, not to make them pressured.
Okay.
So I'll wait for.
ياخدوا قهوة كده يشربوا قهوة.
Yes, exactly. Freshen up.
Refreshing, some refreshing.
بالظبط.
الله يرضى عنك، تسلمي. Okay, thank you.